Hi, my name is Francois. I'm a Director of Advanced Urological Care, a practice that is focused on the treatment of advanced erectile dysfunction. I find that approximately 40% of men who suffer from erectile dysfunction do not respond to first-line therapy, meaning Viagra, Levitra, or Cialis. There are certain groups of patients that we define as difficult to treat. Those are patients who suffer from diabetes. In that patient population, if a patient has diabetes and erectile dysfunction, there's probably less than 50% chance that oral medication will work. If a patient sustains a prostate cancer treatment in the form of either open prostatectomy or robotic prostatectomy, that patient population, only 40% will actually respond to Viagra, Levitra, or Cialis. So that defines a group of patients that we feel will benefit the most from a more advanced treatment option. Incidentally, we find that about 10% of men after radical prostatectomy will have normal erections if they're potent before their prostatectomy. So we know that 90% will need help. Of that 90%, a good chunk will respond to oral medication. So we feel that about 60% of patients after prostate cancer treatment will need either penile injections or a penile implant to recover their ability to make love. We also offer patients vacuum pumps, urethral suppositories, when oral medications fail. I've actually sat with a lot of patients alone in the room trying to get the erectile vacuum devices to work. It's very, very difficult. I invite physicians to actually try to use these things. Just to get the rubber band on the vacuum chamber is extremely difficult and actually painful. At times I've actually snap the rubber band on the base of the penis and then try to get the vacuum pump off the penis, and at times it's also quite painful. So those options, which to us doctors seem like a quick fix, are not so simple, and I invite doctors to actually take it a step further. I think the ideal candidate for a penile implant is a motivated patient, a patient who wants to be cured, a patient who has tried other options and has failed, and of course we want a patient that is medically safe, a patient that doesn't have a lot of underlying medical issues that will make it a problem for that individual to have a penile implant. There are several types of cylinders. I find that the Coloplast Titan cylinders give a great axial rigidity. What I really appreciate about that cylinder line is that I can really tailor the cylinder to the patient. It comes in many, many different sizes, starting at the 12 centimeter all the way to 28 centimeter. So having this flexibility to use the right size for the right patient is something that I really like. I don't particularly recommend using rear tip extenders. Rear tip extenders do not inflate, and the pseudo capsule of scar tissue that forms around the base of the implant over time loosens up. And so even though the patient is able to get a good erection by pumping the implant, the base of the cylinder will start to wobble over time, and the patient will complain that the erection drops down instead of pointing up. When the patient gets an erection, the whole cavernosal chamber fills with blood. So really the best cylinder is a cylinder that actually inflates completely, so that the rear of the cylinder should also inflate in order to buttress the penis against the pubic ramus and ischial bone. There have been significant advances in the implant over the years, beginning with the antibiotic coating. The lubricious coating makes it easy to use as well. The device is very slippery, so it's easy to insert. And in addition, each physician can dip the implant in whatever antibiotics they feel is appropriate given the bacterial microbiological profile in that institution. And so you can tailor the antibiotic treatment to best protect your patient against an infection. So the hydrophilic coating alone, just with saline, prevents the adherence of bacteria to the device as it's being implanted. Fortunately for us, skin bacteria that come into contact with the devices are very benign. Infections are relatively uncommon. We feel that approximately we could number between 2 to 5% infection rate, an overall infection rate, more perhaps towards the 2% rate. However, we also know that infections tend to be underreported. Now, when an infection occurs, the whole device needs to be removed. What we find is by adding an extra step to the surgical regimen, including intravenous antibiotic, careful preparation of the skin with a alcohol chlorhexidine chemical, and in addition using an antibiotic-coated implant such as the Coloplast, an extra step is to use the no-touch technique where the device is never really exposed either directly or indirectly with skin flora. Because skin bacteria are benign, the no-touch techniques makes a difference. It makes a difference in that it takes you one other level, and we've achieved an infection rate of 0.38% based on 2,336 consecutive penile implants since 2006 using the no-touch technique in combination with the antibiotic-coated implants. So one of the big risks of infection, I think, is being handled quite effectively. There are some downsides to getting a penile implant, like for any surgical procedure, there is the risk of infection, as we discussed. Every implant at some point is going to malfunction. When it breaks, we'll take it out and we'll put in a new one. The devices are filled with saline. Again, this is something that patients need to be informed. And it's the same saline as one would use for intravenous medication. So it's very safe. When the patient experiences a mechanical failure and the device will leak, then it will not be harmful to the patient. One of the big benefits of an inflatable penile prosthesis is that it's actually deflated most of the time. What we learned from the experience with rigid or semi-malleable implants is that over time, the layer of scar tissue that form around the cylinders, the pseudocapsule, will become looser. And so the erection will loosen up, it will wobble. The space inside the cavernosal chamber where the cylinder is located will expand from the motion of the patient. There is an atrophy that occurs of the flesh of the penis. There's actually an atrophy also of the glans penis. The benefit of an inflatable cylinder is that you can actually deflate it and prevent this atrophy so that when the patient inflates the cylinder, it is well secured in the cavernosal space of the penis. In a similar fashion, the reservoir must be maintained, especially in the first 2 to 3 months after the surgery, in order to form a healthy capsule of scar tissue which will accommodate the appropriate volume. One common complaint is autoinflation. In other words, the patient deflates the implant and then the implant will inflate by itself. Patients tend to blame the mechanical components of the device for this occurrence. However, what happened is that the implant was left inflated in the immediate postoperative period, and eventually at about 2 to 3 months after the surgery, the patient becomes adept at deflating the implant, and the patient is actually transferring more fluid into the reservoir than the reservoir can accommodate because scar tissue formed around a partially filled reservoir. Over time, the increased pressure around the reservoir will push the fluid back into the cylinders, and the patient will complain that an erection has occurred. Autoinflation is more of a management issue of the penile implant in the immediate postoperative period. What is really remarkable about a patient who gets a penile implant is that the first word out of their mouth is how free they feel. And it took me a while to understand what the patients meant. And they all used the same word: I'm a new man, I feel like a free man. And this is what they taught me. When a man suffers from erectile dysfunction, he thinks about it all the time. And there's only one treatment that really fixes the problem completely, and that is a penile implant. Other treatment options, what these gentlemen have told me, actually remind them that they have ED. So even if a patient is taking Viagra, each time that he pops a pill, it actually reminds him that he has erectile dysfunction. And what fatigues a gentleman who suffers from erectile dysfunction is that at some point during the day, they're gonna think about their erectile dysfunction, whether they see a commercial for lingerie, or somebody is making a joke at the dinner table that has some sexual undertones. They're going to be reminded that they have erectile dysfunction. When you fix their ED, they feel so free. So it's a little bit surprising, because you would think that they would come to you and say, oh, gee, I have this device, I am able to have great sex, thank you so much. That comes with it, but the main appreciation of this treatment is the feeling of freedom, the feeling of not having the burden, not being shackled by the erectile dysfunction. Knowing this, I think, is important, because it helps the physician in counseling the patient, especially our younger diabetic males who don't respond to oral therapy and who are annoyed at having to do a penile injection each time they want to make love. A lot of the urologists are times when they see a patient who's in his mid to late 40s, understandably so, want to delay the penile implant option for fear of infection or of a complication. However, there is a cost to that, and those patients are more likely to use the implant more often, and those patients are more likely to love the penile implant.